Welcome everyone and welcome to the COVID-19 Q&A panel hosted by Transplant Families. We are glad that you could join us this afternoon and hope that our presentation is helpful and informative. If this is your first time joining us, welcome. We are glad that you are here. If you had joined us in the past, welcome back for today's session. First, I'd like to introduce myself, Melissa McQueen. I'm the founder of Transplant Families. I currently sit on the UNOS OPTN Data Advisory Committee. I'm a parent leader with Action Network, and I'm mother to Dylan, heart transplant recipient. I'd also like to introduce Jen, she's a board member of Transplant Families. She's the current parent liaison to the UNOS OPTN Pediatric Committee and the chair for patient, family, and engaged partners of SPLIT, which is a Society of Pediatric Liver Transplantation. She's also the mother to Nate, who's a liver transplant recipient. And finally, last but not least, Joseph is our strategy advisor to Transplant Families and a member of the UNOS OPTN Board of Directors. He's a member of Families in Action. He's also father to Ben, heart transplant recipient. Before we turn the session over to our presenters, we have just a few housekeeping notes. If at any point during the presentation you need technical assistance, please type your question or concern in the chat window. If you have audio issues, you should be able to switch between using your computer, speakers, or phone if needed. In order to provide a high-quality webinar today and to avoid background noise, all attendees are in listen-only mode. Questions are encouraged and welcome during the presentation. Questions can be submitted via the questions box, which is located on your control panel. We will be taking questions that are typed in the box during the presentations, so please submit questions as you think of them, and then we will address them during the talk. We will also be recording today's webinar, so you'll be able to access the information again at a later date. The panel discussion was made possible by a grant from CODA, the Children's Organ Transplant Association. We would like to mention an impressive collaborative document produced by Action Learning Network, the Pediatric Heart Transplant Society, the Starzl Network for Excellence in Pediatric Transplantation, and the Improving Renal Outcomes Collaborative, which was originally begun and is still being updated in response to parent COVID questions and concerns. Please visit www.actionlearningnetwork.org/COVID-19 and scroll down to the facts section or download in the handout section of this panel discussion to read more. This document is meant to complement today's discussion. At this time, I'd like to turn it over to Jen Lau.
Thank you very much, Melissa. First, we'd like to thank Chicago area caterer Feast in Imbibe, which is operated by a family whose son Avery was an organ donor this past January. Today, they fed the emergency department at Lurie Children's Hospital of Chicago. We would also like to thank Phoenix area restaurant Intentional Foods, operated by a bone marrow transplant recipient family. They will be feeding the Phoenix Children's Hospital emergency department next week. These centers represent our two largest in-person support groups at this time. This coming week of April 19th is National Pediatric Transplant Week, which was created in concert with the pediatric community to honor donor children and to raise awareness of pediatric recipients. In support of the week, we are working with many organizations and are glad to be co-hosting 2 more webinars with Children's Cardiomyopathy, sorry, I'm a liver mom, Foundation, as well as sharing many other awareness initiatives. And we do encourage you to tell your own story of transplantation on social media during this week. We would like to honor our donors by continuing to celebrate Donate Life Month during April, Blue and Green Day on Thursday, and National Pediatric Transplant Week beginning with our own virtual resources fair beginning at 1 p.m. Eastern, 10 a.m. Pacific. Links to further events will be emailed to you following the end of this event. Now it is my distinct honor to present Dr. Mazariegos, Chief of Pediatric Transplant at UPMC, Children's Hospital, Pittsburgh, UNOS OPTN Pediatric Committee Chair, and Chair of Starzl Network for Excellence in Pediatric Transplantation. Welcome, Dr. Mazariegos. Let me know when you would like for us to advance your slides. And first, if you wouldn't mind telling us about your son's COVID Easter egg that we see.
Yes, I want to give all credit to my son Mateo, who took on the spirit of the current times and decided to make his Easter eggs with a COVID theme. So This is Mateo's contribution to our Easter egg hunt for this year. He is 12. I have a 14 and a 16-year-old also, and really honored to work with Jen, with Joe, and with Melissa in this, and all of the co-panelists today on this important discussion. So thank you for having me. I was asked just to give a brief introduction, more just to set the scene before we get into the real heart of the discussion and get to hear from our experts around the country and across North America, by giving some updates on what we know in the pediatric realm in terms of the impact of COVID, the impact of this in transplantation, and really to give a little bit of background. A lot of it is emerging, and we're getting new information all the time. And you've got all the experts really in the country here to help really give you some reassurance of some, in the midst of all this, some good news, really overall, that our children to a great degree have been spared, and we still have a lot to learn, but we are going to get through this. So if you can hear me okay, I'll go ahead and get started with the first slide. This is just data that was presented, and I put this together from the AST town hall that was presented 2 days ago. It was an hour-and-a-half presentation, and the full recording is available on the American Society of Transplant's YouTube channel, which Joe listed for you in that bottom link there. So that'll be sent out by the organizers for everybody. I have just selected a few slides from the presentations, and I'm going to show data from Dr. Clausen, who's the Chief Medical Officer of UNOS. And I'm going to show some data from Olivia Cates's registry from the University of Washington, just to give all of the listeners some background data on what we know currently of transplant impact from COVID. And then this is just a couple of minutes to give you some high-level information, and I'm sure we're going to get to more specifics in the Q&A. Next slide. So first, I thought it was important, because of the passionate advocacy of transplant families for organ donation, to just acknowledge that there has been an impact on organ transplantation nationally because of COVID. And this was data presented by Dr. Clausen. And the next slide shows really two main messages right now. It is important to acknowledge that organ transplantation activity has significantly decreased in the past month. This is true for both deceased donors and for living donors. This is data that, again, this was true as of the Monday of this week, but looks at a day by day, week by week progression of the impact of what's happened to deceased donor transplantation for all organs in the United States and by region. And you can see that it's taken about a 50% impact in the decrease of deceased donors. I don't have the living donor data shown here for the sake of time, but kidney donation in many programs, and this is mostly affecting the adult population, but also affects children, has really slowed significantly. Living donor liver transplantation has been more maintained, but it is doesn't represent the activity that kidney donation does. And so there's been a big decrease in living donor kidney transplantation across the country, and in some regions more than others. And then the next slide, we show the impact across by organs. And so this slide, again, all of these slides are available in the full recording, and can be a resource for the families and patient advocates on this call. This was data, again, that he showed looking at how the impact for kidney at the top, then liver and heart, and as well has been impacted with that kind of start of the decrease being about the mid-March time point. And you can see that that has still not reached a definite plateau, although it looks like it's plateauing right now at about 50% of the kidney activity. In some areas, it's started to increase again, and in others, it's still not quite reached its plateau. So we can acknowledge that each program and each organ system is handling the responses in a manner unique to their program, but there are some factors such as COVID presence in ICUs and in donor hospitals and in certain regions that indirectly also impacts whether or not a patient can be called for a transplant or whether a donor can be recovered. Even if a program is willing to continue to do activity, they may not be offered that donor, or there may be challenges in recovering that donor for a deceased donor, for example. So this is an issue that I wanted just to mention, and it is very program specific and to some degree regional specific. And we can talk more in the Q&A about questions that you may have about this specific to your region or to your organ question. And the last part that I wanted to just briefly mention was what we know about data that's being collected, and Laura is one of the experts in terms of registering and trying to record transplant impact for children. But I wanted to show some data from the University of Washington. Olivia Cates is an ID fellow at the University of Washington, and because they were early on at the center of the activity in the United States, they began a registry that tried to record any transplant patient of all ages in all organs that were diagnosed with COVID. And the next two slides, if you could advance that, please. And one more. This is a word summary, and then I'll show you a couple of graphs just to give you some overviews. The data in this summary is of 120 patients, mostly adults, who have been diagnosed with COVID disease and have had a transplant. The median age is 56 years, and actually I found out today, and on the webinar she said that less than 10 cases have been reported. It's actually specifically 6 cases have been reported out of the 120 total cases, and so the pediatric population represents a small subset of their overall registry database that they've collected so far. The main descriptive take-home message is that of these 120 patients, most have been kidney recipients. There have been some liver recipients, 15 heart, 10 lung, and 3 pancreas recipients. Most of these patients were patients that were diagnosed at a long time post-transplant, but there were 16 patients in their registry that were diagnosed during the transplant admission or very recently after transplant. They were on a variety of maintenance medications that are shown here, mostly tacrolimus. Most of them were on prednisone, and most of them were on a third agent, usually mycophenolate. And for the recent transplant patients, they had a subset of them had received the induction therapy that are common in these patients, including thymoglobulin, ATG, basiliximab, and alemtuzumab in one patient. And these patients had a variety of symptoms, but mostly fever, cough, and dyspnea. But there were also associated symptoms of fatigue, myalgias, rhinorrhea, and even some GI symptoms. In the next slide. You could advance one more slide, please. This just shows what the findings have been in the cohort. If you could go back, thank you. In this cohort of the 120 patients, 30% of them have been maintained as outpatients. This is consistent with our own experience at the Children's Hospital of Pittsburgh, where we've had 2 children that have tested positive with relatively mild symptoms and were managed as an outpatient with resolution of those symptoms. In our experience, we had one heart patient and one liver patient that were several years out after transplantation that presented with fever or a cough and were tested and were treated as an outpatient. In the series in University of Washington, 70% of the patients, so the other cohort, were hospitalized, including 49% that did require intensive care support, and 19% of them who were intubated. This is very early data, so we don't have outcomes data from this cohort. It's less than 28 days of reporting so far, but the data was important to kind of show what the initial treatment has been. And in the majority of these patients, they did receive one of the proposed therapies, including Plaquenil or hydroxychloroquine, 17% azithromycin, and then a smaller subset of the antibodies, remdesivir or tocilizumab. Most of the patients did have some reduction in their immunosuppression as part of their treatment, most commonly reducing the third agent or the antimetabolite, which has been a relatively consistent part of some of the other reports from across the country, such as the Italian experience. The general take-home messages from this data have shown that, as I mentioned at the beginning, children, in what we know now, have been a small subset of the affected population. There is not data to generally support that these immunosuppressed patients are more likely than others to obtain COVID, but this is an important area that will need to be reported on and followed more closely. And there's going to be work done by pediatric experts like Dr. Lara, who's on the panel, to collect some pediatric specific information, and she may speak to how that is going to be done later in the discussion. But I hope that this gives you an idea of what we know this week in terms of the impact, and to help kind of start off the discussion with this background. I'll turn it back over to Joe and to Jen to kind of take us through into the discussion from this point.
Yes, hello, thank you. So I would like to remind everybody that invited panelists' opinions of their own. We recommend that panelists should always check with their own team before making any changes related to their child's medical care. This panel discussion should not be construed as specific medical advice. We would like to welcome our panelists who come from a wide variety of professional backgrounds, and we are hoping that their diverse perspectives adequately address all of your concerns as parents. Our first panelist is Dr. Sandra Amaral, Medical Director for the Kidney Transplant Program at the Children's Hospital of Philadelphia and Associate.
Hi, everyone.
Infectious diseases for
Hi, Joe. I think we lost you. I'm going to go ahead and take over if that's okay. All right. We are going to go ahead and we just welcome Dr. Sandra Amaral. We're very glad to have you here. We're going to continue on and welcome Dr. Kevin Daly, Assistant Professor of Pediatrics at Harvard Medical School and Cardiologist for Advanced Cardiac Therapies for Boston Children's Hospital. I'll carry on with the, oh, hi, it's good to have you here.
Thanks.
Dr. Lara Danziger-Isakov, Professor of Pediatrics and Director of Immunocompromised Host Infections Diseases for Cincinnati Children's Hospital Medical Center. We're welcoming Dr. Reggie Durst, Clinical Director of the Stem Cell Transplant Program at Ann and Robert H. Lurie's Children's Hospital of Chicago and Associate Professor at Northwestern University Feinberg School of Medicine. Welcoming Molly Dugan, lead social worker for Advanced Cardiac Therapy Program, including heart transplant, heart failure, and ventricular assist devices at Children's Healthcare of Atlanta at Eggleston. Welcoming Dr. Antoinette Fletcher, instructor with the Einstein School of Medicine, Division of Hepatology and Clinical Transplant Pharmacy Manager with Montefiore Medical Center in Bronx, New York. Welcoming Dr. Vicky Ng, Medical Director of the Liver Transplant Program Transplant Center, staff gastroenterologist for the gastroenterology, hepatology, and nutrition for the Hospital for Sick Children. Welcoming Dr. Mark Schechter, Clinical Director for the Pediatric Lung Transplant Program at Cincinnati Children's Hospital. Welcoming Caitlin Shearer, Registered Nurse and Kidney Transplant Coordinator for Solid Organ Transplant at Seattle Children's Hospital. And finally, Dr. Diana Schalmer, Associate Professor of Surgery and Psychiatry and Pediatric Psychologist for UPMC and Children's Hospital of Pittsburgh. All right, Joseph, have you rejoined us?
I believe so. Can you hear me?
Yes, you sound great. I'll let you take over.
Okay, yes. So we welcome our wonderful panel, and now we'll begin the questions and answer. The first question is for Caitlin Shearer. It is, what sort of precautions are providers taking for families who are inpatient or visiting for clinic?
Well, so I can only speak to what we're doing here in Seattle, but I'm sure everyone's aware that everything's changing pretty frequently. And so the recommendations have changed almost every day, it feels like. But now I would say most hospitals are restricting visitors. Here at Children's, we're only allowing one parent per child for any lab visit, clinic visit, hospitalization, and no siblings are supposed to be at the bedside. We have tried our best to convert most non-urgent clinic visits to telehealth or phone calls to limit the number of people coming to our main campus here in Seattle. And then all staff members who are interacting with any patient are wearing full masks and eye protection. And we're also screening everybody at all of our entrances, and we're isolating people right away if they're having any symptoms of COVID-19. And for our transplant patients who have to come here for labs, we have been putting them directly into a room, and they won't have to wait in the waiting room or anything like that. And so I think a lot of centers are doing it that way as well.
Does any other panels have anything to add to that?
This is Sandy Amaral. I know at our hospital in Philadelphia, we recently implemented sort of like almost like a concierge service, where if patients are symptomatic, they're actually welcomed at the door and sort of shuffled away to a special unit for evaluation. That's for all patients, not just transplant, just to try to keep any symptomatic patients separated from patients who are coming in for routine visits. Other than that, I would say very similar practices as Seattle. I think that right now, our staff are not necessarily wearing visual protection. Everyone will be masked. So if a patient comes to the door, their family member, everyone will have a mask on. But the visual shields are really being reserved for patients who are symptomatic. And I'm not sure, Lara, if you have any expertise or guidance about that. But at least at our center, if someone's not coughing or febrile with symptoms, then we're just using masks if that's normally what we would use, unless there's some other reason that we would need more gear like visual protection.
Yeah, I think it varies from hospital to hospital. Patients and family members are generally often now being requested to mask when they come into institutions, for visits, for whatever that may be. Many of us, you'll see that your providers are masked. Some institutions, our institution, we mask and wear eye protection for all direct patient care across the institution. But I think that's really just variable based on what is available and what is routinely able to be used at different places. I think the biggest thing is not to be surprised when you go for a visit that it's not the same as it was when you went for your annual visit 2 months ago or 6 months ago, and to be understanding that the process may take longer than you expect it to.
The one thing I would add from our center experience is that aerosolized generalizing procedures have been treated a little bit differently, and that involves anything that involves manipulating the airway, like intubation or LMAs. And so when we have patients that are coming in for scheduled biopsy procedures or anything that might require anesthesia, our hospital is now testing everyone 24 hours before those procedures, which is forcing patients and families to come in to the hospital twice, once for the test and then the next day for their procedure.
Lurie Children's in Chicago has also added the screening for surgical procedures a few days before. We initiated that for the stem cell transplant patients, that they would be screened at least 48 hours before that we'd have a result before starting. The thought being that we wouldn't want to introduce a strong immune suppression right if they were positive, and we had the option of delaying. And the other factor was to not knowingly bring in a patient to the hospital who was already positive and potentially would expose the staff and other patients indirectly for that. And last Friday, they did a screening of all the hospitalized patients, whether symptomatic or not, and there were a couple asymptomatic patients who were detected. And so upon admission, the hope is to screen everybody going forward.
Go
ahead.
I was just going to ask, in Philadelphia, we're doing that as well. So anybody that's presenting to the ER or for admission is getting tested. Among all the children that have been tested so far, only among those who were just, screened because they were walking in the door but didn't have symptoms, only 5% of all of our COVID-19 positive cases were asymptomatic. So the majority who tested positive really did have symptoms, but we are universally testing everyone.
Sure. Actually, thank you very much for everybody for fielding that question. We're going to move on to the next one now. The next question is a predictable one. This is for Dr. Danziger. Do we know if and when there will be a live vaccine?
Do we know if and when there'll be a vaccine? So I dropped the word live out of that. So do we know if and when there'll be a vaccine? So there are several vaccine candidates that are under evaluation. Some of them are starting to be studied in clinical trials, and those have to go through the various phases of clinical trials, usually phase 1, starting with healthy adults who will be tested to see if they are, if there's a appropriate safety and if it's even considered that it will create the appropriate antibody response that they want it to create. So there's at least half a dozen vaccine candidates that I've heard about. I'm sure there are many, many more. And generally, from the time of a vaccine being introduced and for evaluation, it can take anywhere from 12 to 18 months, or in some cases longer, depending on the success of the early attempts with those. But there are a lot of candidate vaccines out there that people are working on to get tested.
The follow-up question for that is, will this be safe for our children?
So it will go through a progression, right? So they'll start with healthy adults, and they will target populations of patients to test serially over time to check its safety as they go through that process. Because this virus appears to preferentially cause severe disease in adults, with less severe disease in children. My prediction, I guess, would be that it will be primarily focused on getting it out into adults, but also that it will then trickle down into pediatric patients. I think that the question about safety will be something that will be important, and I certainly, for one, have been talking with our vaccine unit and with others about the fact that that our patient population, kids who have abnormal immune systems, need to be included in some of these trials so that we can ensure that we're protecting everyone who's vulnerable.
And do you think herd immunity, what is the importance of herd immunity with regard to that population?
I think there's a lot we don't know about this virus yet and about its kind of long-term effects, as well as what the cycle of it is going to be like and whether or not people can become infected with it, if it's going to have a seasonality similar to what we see with some other respiratory viruses like parainfluenza that can circulate and you can get more than once, but maybe it's less severe the second time. So I think those are all things that we have yet to know and to discover, because there really hasn't been enough time for us to see how that plays out. And as we gain that information and it's shared, then we'll have a better idea of how to provide, the right recommendations and the right suggestions to patients and families about how to, stay safe and stay healthy.
So I would like to direct part of that question to Dr. Ng and Dr. Mazariegos, being liver specialists. Many liver children have different considerations in terms of what vaccines they receive. Do you feel that you know anything enough to make any sort of statement for that population?
Vicky, do you want to go first?
If you could go ahead, Dr. Mazariegos.
I think for our liver population, I think we would follow the same considerations that Dr. Danziger has mentioned, and that is that while we're in this, while we're transitioning as a community to potentially use live vaccines, for now we have traditionally focused on passive vaccines, attenuated vaccines after the post-transplant period, and so that would be, for the issue of safety, maybe the focus that we would continue to trial those attenuated or passive vaccines rather than live vaccines.
Can I interrupt, Dr. Mazariegos, for a second? Let me be clear that the majority of vaccines that are being proposed and developed are not live viral vaccines. So these are vaccines that are using parts of the virus that wouldn't be able to replicate on their own. So it's more similar. So it's not like MMR or varicella that they're talking about. These are pieces of vaccine similar to what influenza would be like. So the influenza vaccine, which is actually, a part of the influenza virus, so that it wouldn't be necessarily a live vaccine. And those are the vaccines that are being proposed currently.
Perfect. Thanks.
Vicky Ng. Sorry, could I speak? This is Vicky Ng here.
Go ahead.
Can I? Oh, hi. Sorry, Joe. I was just going to further add to the comment to say that I think ultimately, as we move forward with a lot unknown, is that everything is sort of like a risk benefit. And so for the liver transplant population, I would say that it would be important to be in contact with your healthcare providers. And certainly many of the children who are long-term post-liver transplantation are on very low amounts of immune suppression. So certainly one could, put that in, despite the general teaching that live vaccines are a taboo. The field's certainly changing, and those who are on low amount of immune suppression would certainly be more receptive as a healthcare provider to receiving vaccines, should they be live. And as Dr. Lara was saying, if they're attenuated and passive, then that would be no concern. Thank you.
Does anybody else want to add their specific expertise to a specific commentary? Hearing none, then I have a question for Dr. Durst. This question is, regarding cancer survivors. Specifically, this person's daughter had hepatoblastoma that metastasized to her lungs. She's been in remission for 8 years, and she noticed in the fatalities that she's read about that quite a few had cancer in their past but had recovered. Is there a correlation between respiratory severity and cancer? And I guess that question could be directed to a couple of panelists, actually.
Yeah, I don't think the easy answer is that we don't know, because this is a different situation. I would like to think that for someone who's 8 years out, that based on experience from long-term survivors in general, that their immune system should have recovered quite a bit. And if the sequelae to the lung, if there was not a lot of surgery required, or if their lung function has returned pretty close to normal, that they would be not at a, I would not expect a higher risk than someone else who had no lung involvement or no cancer by that time. But I'd certainly, in terms of whether Dr. Schechter, the sorry, bad at names, Dr. Danziger would have any thoughts there.
If neither of those doctors have anything to add, then we'll move to the next question. And this is for everybody. How should frontline worker parents, that is, for example, someone who's working in a grocery store or otherwise healthcare environment, et cetera, how should they handle returning to their transplant children?
This is Kevin Daly from Boston. I think that's a really hard question, but I would thank any parents that are frontline workers that are out there doing their job despite all of this. It's something that we all as medical providers deal with to a greater or lesser extent. Some of the things that I've done for myself and for my family is to wear scrubs to work lately. And when I come home, I change immediately and I take a shower. So at least I minimize what I'm bringing in to the house on my clothes. The second thing that I do is we are wearing masks at work, and so I'm trying to be really good about that and keep social distancing in place. And I think that those are, sort of the things that you can do. I'm good about hand washing. Masks are only protective if you sort of keep the virus outside the mask, and so if you take the mask off and rub your face a lot, then those are ways that you can get potentially sick. So I think those are some of the things that we can do. That being said, I know of at least 2 of our families whose parents work in a healthcare setting who have contracted the virus. One of the families actually isolated themselves completely from their children to try to protect them, knowing that they were possibly going to get infected. And the other family was unable to do that. The other thing I would emphasize, though, is that this is a virus that we really need to think up the generations and worry up the generations as opposed to down the generations. Most of the data for kids has really been reassuring. And so I worry a little bit more about a transplant child giving it to their parents or to their grandparents than I worry about things going the other way around.
Does anybody else have anything to add to that? Okay, so we're going to now ask what is probably one of our #1 questions that we receive. Not that the others haven't been also of high priority to parents, but parents are very concerned about what to do in terms of school, particularly if schools open at the end of this month, or even if they don't, what to do about summer camp, summer school, or will it even be safe to return in August? We know that our children are quite different from typical students. So who would like to field that?
That'd be me. So I think that this is Lara Danziger. So I think that there's some things that you can use as tools to help you make those decisions. Number one, you should absolutely rely on your local transplant team to help you make those individual decisions, not only based on the risk of going to school, but your individual child's situation, what medication they're on, what needs they have at school, if they have, any type of very, specific things that have happened to them recently. All of those things need to be discussed with the primary provider and your transplant team to help you understand that. But there's also some other general tools that are really quite helpful. And sometimes people do a really good job of providing information. I think it's really important for people to understand what the local epidemiology is in their county, in their state, in their region, so that they can address what the specific risk is likely to be for their child to return to school. It may be very different if you live in Boston, or if you live in Philadelphia, or if you live in Cincinnati, or if you live in Pittsburgh, or Texas, or Seattle. All of those places are going to have a microenvironment that will help you determine what the risk to your child can be should schools come back in session. And I think that that's a really good place to start. That information is very readily available. I think probably everyone on this call has gone to the Johns Hopkins coronavirus dashboard. You can get information that's very specific to your local environment, and that should be very helpful. And I think that that's really how you have to start the conversation, with looking at your individual child and looking at your individual environment. It also has to do with what your relationship is with the school that your child is at, and what type of information they're willing to share with you regarding, number of kids who are out sick and things like that. If you have a different relationship with some of the teachers, using those channels of communication and expressing your specific concerns for your child should really be helpful. And I don't know if Diana might have some other suggestions, or if one of the social workers might how to navigate that. But I think those are all things that people can use in order to make an individual decision for their child.
Sorry, Dr. Shelmer, we're going to unmute you here. Could you speak again, please?
Okay.
Yeah, we can hear you now.
Yes, hi, it's Dr. Shelmer. So I would like to add that for most transplant patients who have returned to school or had been attending school, many of them have what we call 504 plans, which informs the school regarding their specific medical needs. If your child has one of those, many of those plans can either be altered and or being augmented, in that you can add information so that you can know if there's an outbreak of a particular disease within the school system itself. And when it comes to COVID-19, many school systems, and I can only speak specifically for Pittsburgh, but have continuously provided updates in regards to presence of the virus within individual schools and within individual areas and counties within the area. So you could utilize that in addition to what has been already discussed in order to guide your decision making about whether or not to also send your child back. You can also communicate with the school, particularly if there is a 504 plan in place for your child, because under those conditions, that's sort of a mandated federal plan, where the school would have to have some level of responsibility in regards to talking to you about it. What some people may actually face is sort of the reverse, in that some school systems, when they fear for the well-being of specific vulnerable children, they may advise you to actually not send the child in. However, those 504 plans then provide many times for tutoring within a home environment until the child is then able to return to school, or provide additional guidance in regards to what to do in order to continue their education. So you still have some additional resources so that your child does not suffer academically, but can be protected from the stance of their health and well-being.
I think Dr. Mazariegos, you have a follow-up to that?
Yes, thank you, Joe. I agree with Dr. Schelmer. And also, I just, noticing how many we have, almost 400 people on this call. There are multiple levels of immunosuppression I'm sure that your children are on, and there are multiple organ types. I think from what we're seeing, and maybe I'd like Dr. Lara Danziger's comment too, but I think one thing that we can say about the school question is that it's likely less related. The answer to the parents' question about that is probably less related to the organ type or the amount of immunosuppression that we're on than general issues happening in the community. And for example, of the patients, we have knowledge of patients who've been infected early after transplant, and even on a relatively high level of acute immunosuppression, and have been diagnosed as positive and have recovered. Others who are further out after transplant in both organ types that have had a higher amount of immunosuppression or a lower amount. And it seems that for reasons that we don't completely understand, that that the impact of that on the immunosuppression levels per se haven't clearly been associated with an outcome. And so I think it's probably again, the issues that Dr. Schelmer, that Dr. Danziger talked about, the general impact in your community, the prevalence in your school are maybe more important than the specifics of the time post-transplant or the organ type.
Does anybody else have anything to add to that?
This is Molly from social work. I would just also recommend that parents, you guys are the best advocates for your children, and you can work with either the educational advocate at your program or social worker to try to make the best decisions, and the medical team who knows your child can also help you get the documentation you may need. So that would just remember that you've been advocating for your children since before they receive their transplant, and that will just be another opportunity for you to do that with your school system. But you do have people that can help you with that.
Any further comments? I think we can, go ahead.
Hi. Just to kind of piggyback off what Dr. Mazariegos was saying, I think something that what the parents would want to discuss with the team was when the patient was transplanted, what their induction agent was. Because if the patient got thymo or alemtuzumab, that's a lot more invasive than maybe if they got Stimulect, or if they had a recent treatment for rejection, maybe it would be a case to kind of continue the homeschooling until the team felt they were at a place where they would want to go back into the environment.
Okay, so moving on, we have a question from an attendee who would like to know about COVID-19 possibly causing endocarditis, and they are curious if it could affect the body in other ways. And I think that kind of drives a question for all the different organ types of effects upon, for instance, liver, kidneys, et cetera, specific things that could happen after a child has been infected. So I will direct that first to Dr. Daly, and then from there.
Yeah. So, I guess I should preface this by saying that I haven't directly treated any patients, especially in the ICU, with this virus, but I've been also trying to understand very clearly what its manifestations are. And for patients that have more severe forms of illness, there are two things that have struck me. One is that there's a particularly high risk for patients that wind up in the ICU of at risk for clot formation, and that there is a syndrome of cardiovascular collapse. It's mostly seen in adults, and people have speculated about whether it's myocarditis. There's been no evidence that I have seen in any pathological series that it's actually true lymphocytic myocarditis, and that it seems more like a hyperinflammatory state that's causing heart failure or causing microthrombi in the vessels. That all being said, I have not seen any reports of that occurring in children or in transplant patients, and the risk of hospitalization for children is really much lower, and we're not seeing those severe manifestations in kids.
Would anybody like to add their own organ-specific knowledge to that?
This is.
Oh, go ahead.
I'm sorry. This is Mark Schechter. So clearly, what we're seeing is a lot of lung involvement, clearly because it's a virus, and that's obviously a bigger, the biggest organ that's being affected. And I think really the question is we haven't really seen it in children to this degree, so it's hard to understand specifically within pediatrics. Again, this idea that it is some type of overactive immune response causing a lot of the damage and some of the issues is something that we're still trying to figure out. What the long-term sequela will be for the adults, for kids who end up in the ICUs is sort of unknown at this point in time. Obviously, from a transplant specific standpoint, anytime we have a lower respiratory tract infection, we are concerned about rejection episodes, scarring, and other things that would lead to chronic lung allograft dysfunction. We know that out of Italy, and they reported on 6 lung transplant patients in adults. 2 died, 2 were managed outpatient, and then 2 recovered. And that's really the numbers that we know. I know the data out of University of Washington only has 13 patients in there, and I know that there were 5 deaths, but again, they're all in adults. So the long-term sequela is unknown, but something that we'd have to watch very closely.
This is George. I just wanted to add very briefly that the AST seminar did have some interesting presentations for those who are interested on data about the cardiac involvement, the renal involvement, and the lung involvement that are of note and are growing rapidly. It does sound like there's several organs that can be affected by those who are ill with COVID. And there's interesting work that is presented on that seminar that's available on YouTube if anyone wants to look at that after the presentation.
Just to add, in terms of the kidney, I think that many times when people get sick for other reasons, their kidney shuts down a little bit or gets injured from either the treatment or the actual illness. And so I think we're still trying to figure out among the reports of patients who've had, not just transplant patients, but any patients who get COVID, is the kidney injury that they're experiencing directly related to the infection or related to being ill from an infection. I think there have been some, I think out of Italy, there were some data where they did autopsies on some patients who had passed from COVID-19, and they did see some viral antigens in the areas of the kidney, the tubular epithelium, but they also saw lots of inflammation. So again, it's still very confusing and we're learning more. I will say, although many patients do have kidney injury, again, we hear and we focus a lot on the deaths, but even among transplant patients, many of those patients have very mild disease. And so I think it is, important to remember that even if among, these solid organ transplant patients, you may just end up having a child that, especially in children, who has, a runny nose, a little bit of cough, a little bit of fever, but gets better, does not need to be hospitalized, does not have a severe illness where they have to be admitted to the ICU.
If nobody else has anything to add, then we will ask the panelists about telehealth. Obviously, the laws have changed regarding telehealth, making it more permissive. I guess what are some of the strategies and benefits that your centers have utilized? Like, what have been some of the benefits, and what's the uptake been like? So I'll open the question to the floor.
This is Mark Schechter again. So when all this started, we basically decided anything elective we would do, we would cancel everything that was elective and then do everything by telehealth. And we've been slowly ramping up. I think a lot of it has to do with connecting with the families and the patients. I think everyone's under a lot of different types of stress. And I think it's helped to make that connection. Clearly, when you do that, we're not able to, for us, listen to the lungs or anything like that, but we can use some of the other data that we oftentimes use, how quick they're breathing, what they look like, what their home PFTs are, and things like that. And so I think it's actually been helpful, more so from really connecting with our families and knowing that, yes, we're not able to see you as we were planning, but we're here for you and we can do some things and handle some things. And then when needed, we brought patients in, but luckily that's been a pretty rare need at the moment.
This is Sandra Amaral. I was just going to say, I would agree. We're slowly ramping it up. I think some of the advantages are, some of our patients drive very far to come to our appointments. And so that's actually helping. It reduces travel time for them and burden. It's also nice for them to see, me in my little home office, and I get to see them in their home setting. And so there is some sort of less formality, I think, that actually is kind of refreshing. I agree that some of the limitations are related to the physical exam. And then I would say that we're still ramping it up. In the beginning, there were some technical glitches and people would get disconnected and things, especially when we first started going to telehealth, because our community was just overwhelmed with people remotely working and using telehealth. That's getting better. But we're still navigating the system and sort of figuring out. Sometimes we get disconnected and have to reconnect. I think one concern that I have is for patients who don't have good internet connection or lose their phones and don't have computers at home. That's been a challenge that I know our institution is trying to figure out how we can make sure that the move to telehealth doesn't disadvantage anyone, doesn't increase a gap in access to care. But I would say other than that, it's been really a great experience so far.
Any other comments?
I just briefly to follow on Dr. Amaral's comment. I think we're in Pittsburgh. We're also just learning, so it's a process of trying to be more available. I do understand that the FCC has, and this is maybe more for the physicians and the team members. They have allocated funds for telehealth connectivity, including anything that would allow telehealth resources to get to patients. And so we did apply for a grant for phones and data for patients who may be have less access to dependable service or phones, et cetera. And these can be loaded with the appropriate video app of your hospital or educational materials. And so I'll send that link to the organizers but it may be something that the institutions, if they're not doing that and have a potential underserved population, may be able to apply to get phones or data to the patients who need it the most.
Does anybody else have anything to add to that? Okay, so the next question is, so follow on to that is labs at home. We've heard of some centers, at least adults, allowing, for instance, tacrolimus labs at home. Are any of your centers utilizing that to prevent, so that our children don't have to go into the centers for those?
So here in Seattle, we actually do have blood spot testing that we do, that we can get a creatinine and a tacrolimus or cyclosporin level off of a finger poke. And so we have been utilizing that for a lot of our kids who are stable and there's not a lot going on. The kids who have positive viruses and other things going on, we are still asking them to go into their lab. But we have offered that to a lot of our patients, and a lot of our kids have actually switched over for at least a month or two. We're still trying to iron out those details, but we can at least get a little bit of information from the blood spot with a creatinine and a drug level.
For our pediatric patients, we're doing outpatient labs at like a local Quest or wherever their insurance will cover, as opposed to having them come in just for routine labs. And then we'll do the telehealth visits.
Hi, it's Vicki Ng here. Here in the north in Toronto, we do try to have our patients have their labs done at a community lab where they can make an appointment, so it can minimize the time that they're waiting. And obviously what we've been hearing recently, that some jurisdictions have had a little bit more challenges getting that sort of first morning lab spot before they take their FK. The other thing that we would say that is we oftentimes will, for those patients who live locally, come to the hospital, but obviously just come for the labs and then go home immediately, and then we'll do the telehealth afterwards. And I think that a lot of our patients have made two observations. Number one is that with the social distancing and everyone hunkered down at home, that the time to the hospital, parking in our hospital parking lot, is faster than it's ever been. And so they're in and out. And the second thing is that they do take comfort because they know that the number of afflicted children or positive children in the hospital for sick children right now is really, really minimal. I think it's just like one. And that has actually given them a lot of comfort in knowing that they're coming to a sanctum as opposed to going to a community lab, which has a lot of elderly patients or other more at-risk adults that may be afflicted and not yet known. Thank you.
Yeah, I would add one thing is we've also started scheduling appointments with phlebotomy. So if patients require labs, they'll actually have a time and they'll be put directly into a room and they won't have to sit in a waiting room. And I think it's actually really great for our patients. And while operationally it may be difficult to do as we fully ramp back up, if it is a positive for any of your patients, if there's anything that works better now than it has in the past, I think it's really important that you let our hospitals know that, because we've been advocating for that kind of service for some of our transplant patients for a long time. And sometimes people listen and sometimes they don't. But if they hear that we're doing something better now than we ever have, then I think it's something that people will want to continue.
If there's no other comments, then I have a question for Dr. Fletcher. Parents are very concerned about the supply chain for medicine, specifically their transplant medicine. Should we be taking any special action as a result? And then I have another question for you after that.
As of right now, there hasn't been any proposed shortage of tacrolimus, cyclosporin, steroids such as prednisone, prednisolone, or the mycophenolic acid. But about a year ago, there was a ProRef shortage. So the thing I'm recommending is you have at least a 2-week supply of all your maintenance medications. A month would be ideal, but not all insurances will allow that. So you want to have at least a 2-week supply. What I've noticed in the New York City area is, pharmacies are an essential business, so they are open, but they've been cutting back on hours. And if there's an outbreak of COVID in the pharmacy, that pharmacy will have to close. So you don't want to be stuck in a situation where you need your medication, your pharmacy's closed, and it may be a weekend, maybe you can't get in touch with your center and you have no medication. So that is important. But as of right now, there's been no reported shortages of maintenance medications for transplant. So you do want to make sure you have enough. So that is important. You could always call your center and say, can you prescribe a little bit extra because I want to make sure that I have enough, and I don't think anyone's going to have a problem with doing that.
The only thing I would add, we've had the same experience, but also we've had some delays in terms of prior authorizations and things like that going through due to staffing issues at various places. So just again, thinking ahead, and if you're running low, let us know, and our respective teams can help you. But really trying not to run too low is really critical right now.
Yeah, and with the prior auths, there's supposed to be, because of this critical time, they're supposed to be prioritizing and speeding everything through. So if you are having issues, whoever is supposed to be handling the prior auth, so you can even tell the pharmacy that, because it's a criteria medication and it's important to the patient, it's immunosuppression, they're supposed to be able to prioritize them and put them through, so that may help. And if you utilize certain pharmacies, if they're specifically for immunosuppression, usually they'll also advance the patient. In this particular time though, I think the most important thing is you don't want to have the patient come to the hospital to get advanced medication if they don't have to. That's the one thing you want to avoid if possible.
Okay. If nobody else has anything to add to that, then the follow-on to that is, are there any, one of the instructions that many patient parents are told when their child has a fever is if it reaches some threshold, say 100.5, et cetera, and it probably varies from center to center, that's when they should contact their center or take other steps such as cut back cell sep, et cetera. Are centers modifying those recommendations in light of COVID-19, or should we continue doing what we're doing?
Before the doctor tells them, but I think that anytime the child is showing any symptoms of illness, they should contact the center. So even if they have a fever of 99, if they're on steroids, that could be indicative of a much higher fever. So if the patient is having fever, maybe chills, they're coughing, maybe they're having GI symptoms and diarrhea, any symptoms that could be associated with COVID, it would be a time to maybe just reach out and start having conversations with the center. It doesn't mean that you have to make a trip to the ED, but just call and have a conversation saying, this is what's going on, what do you think I should do? And then you at least have a baseline to where they say, okay, start monitoring your child, you can give them acetaminophen. You don't want to give transplant patients Motrin because they take the medication that you take to prevent rejection, either tacrolimus or if you take cyclosporin, it's a little hard on the kidneys, and Motrin is also hard in the kidneys, so we try to just stick to acetaminophen. So they may tell you, okay, if you break out into fever, you can take this, but you also want to get a guideline of when you should start to get concerned. There's also something called a pulse oximeter, and oftentimes we're telling patients to start monitoring that at home if they have a cough or something, or if we suspect COVID. This way we know how well they're breathing at home and when we have to worry and have them come into the hospital. So they may want you to get that at home so you don't have to come in and we can actually keep monitoring you at home. But I don't think, don't feel like you have to wait until things get bad. You have a good relationship with your transplant physician. The minute, and you know your child better than anyone, the minute that you see something's different, you want to give us a call.
Here in Seattle, us transplant coordinators have been sending emails out weekly to our families. And what the message we're sending home to them is definitely to call us if there's any sort of symptom. And then we kind of run through a list. We have a whole kind of list we follow. And then we tell them after speaking with our doctors, if they need to come into the ER to get tested. And if we do feel like they need to do that, we set it up ahead of time with the ER. So they're kind of separated from everybody as a transplant patient. And then we can at least get a baseline set of vitals and a set of labs. And if they do test positive, then we would call them every day and check in and make sure they're doing okay.
One more thing I want to add too is even if they have no symptoms, but let's say a member of the immediate family that lives in the household tests positive, you want to contact the center at that point as well for them to give you guidance on what they want to do next.
Okay.
George, I just wanted to comment briefly that in general, again, the key message is, as has been mentioned by the panelists, to contact your transplant center. In general, I don't believe any center would advocate a change in immunosuppression just because symptoms or a fever develops. So it's something that may be recommended by your team, but it would be done typically after you have a visit with them or consult with them, not beforehand. Although, as we mentioned in that data from Washington, there have many of the patients have had some change in their immunosuppression, and intuitively that is often the first step in caring for some patients. But there's many different distinctions, organ type, level of immunosuppression, and other factors. So we would advocate strongly that when you have those symptoms or questions that you consult with your physician and not take any steps first to change immunosuppression.
Okay, so if there's no other comment on that, then we have a question for both Molly Dugan and Dr. Shelmer. How do we make our kids understand what's going on? And then I have a follow-up to that as well.
This is Dr. Shelmer. I think that's a very broad question. I think one of the first things is to feel confident in the information as a parent that you have and that you feel comfortable in sharing with your child. Taking the developmental level of the child into account, and also their own sense, their own level of anxiety or concern is important. Involving potentially your medical provider into the discussion if you're having a telehealth visit of some sort might be of help. In addition, I would refer any family who's thinking of having a more broad conversation with their child to a variety of resources. I have provided that to the panel and also to our moderators this evening to disseminate. There's a variety of resources from the CDC, from NPR, from the Child Traumatic Network, from a variety of sources, and addresses the best way to really discuss this with a child based on their age and their understanding. I would advise greatly that you first feel comfortable and feel calm when you're having this discussion with your child. That will go a long way in reassuring them. And also in letting them know that there's a number of people working tirelessly on this problem, working to resolve it, working to make it better, so that they understand that there is ongoing work that needs to be done, that certainly nobody has all the answers right now, but that everyone is working together. It may also help them to have a sense of what they can do to help their own community. And so even feeling some sense of control over what steps they are taking as a 5-year-old or as a 15-year-old in regards to keeping the people in their families safe, their friends safe, and others safe by following the rules of social isolation or social distancing, by following the rules that the family has provided in regard to what to do, and washing your hands when you come back in, and following those directions also going a long way in helping calm their fears and helping them feel like an active participant who is not at the mercy of some other force that is out there and that is not as well known to them. Molly, I'm sure you have a lot to say as well.
I'll just speak a little bit for maybe parents of children who are in the hospital awaiting a transplant. I think some of the challenges that we're facing are the isolation from siblings, and we have at Children's Healthcare Atlanta, we have a visitor restriction where just one parent or guardian can be visiting at a time, and that's been quite challenging just in terms of how we try to help kids cope with extended hospitalizations. We've seen that across all 3 organ groups that we work with. I think connecting them with child life and helping them do some kind of play and understanding. I know that around our hospital there have been some coloring books that have been developed, those types of things, and all of those things would also be available to parents that are children at home. And so I know I keep saying call back to your own individual center, but most of these places will have resources. That Dr. Shelmer posted a number of fantastic resources that you'll get through this discussion. So I would just piggyback on what she said in terms of the calmer you are, the more you set the tone, and also don't assume they don't know what's going on. Children are much more perceptive than we think they are, and they are seeing their parents probably more often than they have in their whole lives if parents are working from home or they're just more visible, more present, and that is challenging. So just be aware that kids they're either picking up on things, they may act out a little bit more, they may regress, and that's important to kind of acknowledge that these are not normal times, and so kids will sometimes act out or do things like that in response, and that gives you kind of an opening sometimes to sit down and say, hey, let's talk about this. And so I agree, there's great support and resources through your program, and please reach out.
I'd like to add, if I can, sorry, I'd like to add, if I can, that, the stress level of parents under these conditions, particularly when you feel like you are with a child that's vulnerable in a situation that places you under potential risk, it is understandable also to be overly stressed and to potentially at times not react in the way that you had hoped. So one of the main things to remember, I would say, is to try and be kind, not just to your child, but to yourself, because mistakes will be made and words may be said that you regret or that a situation may present themselves. And teaching your child to recover from those situations is just as important as having discussions regarding this virus or anything else. So being able to acknowledge when maybe you are overly stressed and discussing that with your child and modeling for them how to provide a better response is also really helpful.
Okay, so does anybody else have anything to add to that? If not, then the follow-up question to that is for both Dr. Schelmer and Molly Dugan is, when can we relax again?
I'm sorry, Joseph, I didn't understand that.
The question is, when can we relax again?
I'll jump in on that. I don't know that I've ever met a transplant family. I don't know that I've ever met a transplant family that ever fully relaxed again. I think as a parent of a transplant recipient, you carry a burden that most of us could not imagine. But I think good times ahead are coming. I think remaining hopeful, that is the biggest gift that parents give their children that are waiting for transplants, is that gift of hope. And I think that better times are coming. And so a little bit kind of a funny reaction, but it's a great question. I wish we had a good answer.
What I would add to that is that there are steps that you can take that are practical to relax. You can develop a sense of safety within your home. The steps that you're taking to keep yourself safe. You can review those and also engage in a variety of strategies or self-care for parents, and also teaching your children to do some self-care. So helping them remain on some level of a schedule, helping yourself remain on some level of a schedule even while you're working from home and trying to manage at-home education for your children and a multitude of other factors. And taking some time to step back and just be with your child. It's easy to say to relax. That part is not so easy when you say you're trying to just relax. But you can engage with your child. You can have light moments with your child and play games, engage in social activity with the people that are in your household. And that in itself will provide some sense of relaxation. Also, do not give up the time that is supposed to be yours as a parent. Set some time aside in the evenings to just try and decompress a little bit from your day. Those are all very practical steps that you can take in order to provide some self-care, because the less stress that you feel, the more able you will be to then address any challenges that come the next day. And all those things can work in concert with each other to help you develop a more relaxed atmosphere, even if it's not fully relaxed. Because I agree with Molly, once you've gone through transplant, there's always a sense of something else that may need to be looked at or done or, reviewed, or making sure everything is completed. But taking a moment to acknowledge you've done everything that you can do for the day and you've done your best, and taking a breath is always helpful.
So we have about 10 minutes left. We're going to try and get two more frequently asked questions in the remainder of the time. The first one is for Caitlin Shearer. For those that are on the wait list, this is regarding both living and deceased donors. Are there fewer of them? And also, are inpatient families in danger of being in the hospital?
I mean, I think the slides earlier showed that there has been a decline in like the transplant numbers. I would think that kids waiting in the hospital are, you know, we've set so many restrictions on the number of visitors. Here in Seattle, we've separated anyone who's tested positive with this virus from the rest of the hospital, so they're in their own wing. And I think we've had maybe 2 patients at a time in there. It's been very minimal. And as far as actual transplants go, you know, I think our center has taken the approach that we're looking at offers and we're looking at our patients very carefully and deciding if we think it's good to go ahead with transplant during this time. And that's kind of been our thought process behind it.
This is Kevin Daly in Boston. I want to add, you know, we've done 3 heart transplants in the last 3 weeks. So it's not like we're not transplanting patients. And I don't think there's reason to lose hope or to think that your wait times are going to be particularly longer. In addition, I would say that those patients were actually waiting in hospital for months before they received their organ. Some of them, not all of them. So I think that this current situation presents challenges for sure, but also some opportunities. And I think that we are all cognizant of the need to continue organ transplantation when it is safe for your families, for your children, and for our teams. And we are all working really hard to ensure that we can continue to deliver that life-saving gift.
And this is Lara Danziger. I just want to add one thing. You know, most of the hospitals that your children are going to are being exceptionally careful about the care that they're providing. So actually being in the hospital may be one of the safer places for kids right now, as far as ensuring that they're not being exposed to people out in the community or other people who may be out in the community that come into the home, so that they're not going to be likely to be exposed to people who are sick. Most institutions are screening all of their care providers when they come into work to ensure that, you know, healthcare workers aren't the ones who are bringing illness into the hospital. They're masking for care. They're doing things to help protect your child. So actually being in the hospital may be one of the safer environments right now and going forward while these restrictions are still in place.
I would agree. This is George. I also wanted to add that because of generally universally available COVID testing and screening for the donors, that's been implemented fairly widely, if not universally. And as recipient testing is available, you know, typically we're able to know that, to the best of our knowledge, that when the transplant teams feel that it's a benefit risk in favor of doing the transplant, that they're making that decision to proceed with the recovery and proceed with the transplant for your child. It is, we've also done several liver transplants and a liver intestine transplant since in the last 3 weeks, and are considering all donors for our abdominal transplant patients. But it is something that if you have a specific question, it's important to ask your center if they've changed their transplant activity, if they recommend any change in status for your child. That would be a good question to, if you have questions about that, to make sure that you bring it up with your transplant team and discuss that directly with them.
So I would like to move on to the next question just to make sure we get it out of the way. This is the last question. And again, I would stress for the audience that any questions that we cannot get to, we'll make available to the panel, as well as the joint societies that have the wonderful FAQ. You can find that FAQ in the attachments to the event, the handouts, I should say. And but we will hand the questions over to them and for possible inclusion there as well, or specific follow-up if possible. So the last question is about one that has been mentioned in the news quite widely, which is HCQ and azithromycin for treatment of COVID-19, specifically in the context of our children. I think that's we've had a lot of inquiry about this. I think it's kind of an open-ended question. So I'll start with Dr. Danziger and Dr. Fletcher.
There's no specific treatment. I know that we've heard a lot about hydroxychloroquine on the news, and there's right now a lot of ongoing studies. And I think that there's no specific data we can look at. I think right now there's just a lot of, there's a lot of information coming out of a lot of different, out of Italy, out of China. We even have our own data, but it's really hard to look at anything because there's no, controlled studies done that we can actually look at and decide whether or not these medications are working. The mainstay right now has been hydroxychloroquine. We're also using something called remdesivir, which was used for Ebola, and there is pediatric dosing and guidelines for that. I wouldn't use hydroxychloroquine on an infant, but on an older pediatric patient over the age of 12, if they had a significant case of COVID, I would definitely consider using it. There's other medications as well that we're using, like tocilizumab, and we will know hopefully in a few months when we can look at everything and actually see, did it actually make a difference in patient care? So right now, a lot of the things that we're doing are just kind of anecdotal.
So I would add to that. I think that certainly data that's emerging almost daily. Some of the data that has been reported in the news comes out before it's had an opportunity to undergo peer review, which means that they report the results that they report, and it hasn't been evaluated by a group of people who have, looked into the science and the methodology and had an opportunity to help the authors improve their manuscript so that it's the best possible quality that it could be. And we're kind of in that gray zone where people want information so much. What I would say about hydroxychloroquine is that this is certainly a balance between understanding what is likely to be beneficial to an individual patient versus what is potentially harmful. And certainly there's no data that says that a child or even an adult at home who has mild symptoms would benefit significantly from having treatment. And there are certainly significant risks to using hydroxychloroquine, as well as the combination specifically of hydroxychloroquine and azithromycin related to causing cardiac arrhythmias. And recently a preprint, so has not been peer reviewed, but a clinical trial in Brazil was halted before it finished fully enrolling because there were so many patients who had cardiac dysfunction and arrhythmias related to chloroquine, which is another version of hydroxychloroquine. And so I think it's very important for you to talk with your providers about if or when they think that this is a medication that should be given, but certainly from my perspective, hydroxychloroquine should only be given in a situation where a patient can be appropriately monitored and has to have at least moderate symptoms and require some respiratory support, whether that be high flow oxygen or something else, to indicate that intervention is necessary, because what we don't know is what the real natural history in a large population of patients of this illness is right now. It appears that for kids, it may not be as risky for them, and they may not get as sick as adults are getting, but the risks of giving them hydroxychloroquine may be equal to what it is for an adult. And we don't want to put our patients and your kids at risk by giving them something that we don't know if it's going to have a benefit.
And in a lot of states, like I am in New York, you can't get hydroxychloroquine unless you're in the hospital.
I just want to echo Dr. Danziger's concerns about the quality of the research that's going on right now. So I think that it's really important for the audience as parents to know that, normally if we're trying drugs, we really try to go through very systematic processes and do controlled trials and look at the results and think about bias and is it going to work for everybody or just a certain population? Is it safe? Is it effective? But in the current era where people are just so, desperate and trying to figure out if anything's going to work, there's a lot of literature that's being put forward that hasn't been really critically vetted by experts in research methods, and there are a lot of weaknesses. And it doesn't mean that it's not important, but it means that we have to be very cautious with our interpretations. One of my research colleagues said the other day, expediency is not a good excuse for poor science. Like, we still have to really hold ourselves accountable to making sure that what we're doing is going to be safe and effective. And so while it is important to test things, especially in critically ill patients, we shouldn't be making big generalizations because, most of the cases are small, select patients, and we just really, there's so much we don't know that we could actually cause harm. And so I'd be mindful, even some of the headlines in very reputable publication series, and newspapers and things have been very misleading. And so I would encourage you, if you hear about a new drug or something that is in the news, to call your transplant team and ask them about the validity and what they think about it.
And I'm going to just circle back to something that George mentioned earlier. There are many groups that are collecting information about patients who have this infection. Olivia Cates in the group at University of Washington has done a great job collecting information about solid organ transplantation. There are other groups that are planning, registries, the American Association of Liver Disease. The Pediatric Infectious Disease Society has a very large network of infectious disease doctors, and we're collecting information that's very similar to what's being collected by Dr. Cates for all pediatric patients around the country, so that we can take that information and feed it back, because we know that people will get different therapies in different places, and this will provide us a way to give that information back out to the community, so that should we happen to have ongoing issues with this virus, we'll be better prepared from a pediatric perspective. Because right now, all of the clinical trials that are being done for these, that are being run by the NIH, and primarily by the NIH, but also by individual pharmaceutical companies, are almost entirely restricted to those who are over 18. Some of them filter down a little bit to 12, but the majority of them don't focus on kids yet, because kids haven't been affected as severely. And so gathering this information is going to be crucial in order for us to have some information, so that we know how kids are different and how we need to take care of them better.
So we are over time, and I'm going to pass the baton to Jen Lau to close.
I just want to say thank you for ending on that question. I think it was some really good information for our parent viewers. So I would like to thank for those who chimed in on that last question. It was very educational for the parents. So with that said, for everybody who is listening still and stuck around, for more information on pediatric transplant related COVID materials, please refer to the handout section and the resources on your screen. Again, we wanted to thank everyone for their time, the parents' thoughtful and amazing questions, and our panel's expertise. We hope that you will be leaving this being more informed and hopeful. Again, just thank you to our panel and all of our medical professionals who are fighting every day to keep us healthy and safe. And for everybody that is still here, we would like to say stay healthy and stay safe, and thank you for being with us today.